another items about kinematic alignment TKAs. I correct? Oh, this is kinematics uh, of kinematic alignment TKA. So knee moves around three axes. The first is flexion extension axis, that is the green line. The second is patellar extension flexion axis, that is the red one. And the third is tibial rotation axis. But this is the yellow line. Now, I focus on the flexion and extension axis. This is a green line. Oh, this is the center of the medial condyle and lateral condyle and connect two centers. And then it forms flexion and extension axis. We call it cylindrical axis or condylar axis. Okay, so as I said, the mechanical axis TKA, the standard and reference line is mechanical axis. On the other hand, our reference line is joint line. So in mechanical alignment, we should ignore joint line. But kinematic alignment, we should ignore the mechanical axis. So which is better? No one knows the answer so far. But as long as we follow the precise operation and precise procedure, so result is considered to the same or nearly same. But anyway, concept is completely different. So in a kinematic alignment, the axis and kinematics should be considered based on the joint line. So no, on the kinematic alignment, the flexion extension axis, the kinematic axis is considered to move around condylar axis or cylindrical axis, like this one, or cylindrical axis. So the knee flexion extension is considered to the motion of this virtual cylinder, like this. On the other hand, the flexion extension axis in mechanical alignment is Trans-Epicondylar Axis. So that is the line between the lateral and the medial epicondyle. Their insertions of MCL and LCL. Okay. Oh, but however, there is a difference between two lines, two axes. It is reported as approximately 3 degrees. So trans-epicondylar axis TA rotates externally approximately 3 degrees. We express this angle as osteochondral angle or twist angle. Well, that is the difference. So in many, in most surgeons, cut the femur in 3 degrees in external rotation. Or some doctor measure this posterior condylar axis angle on the preoperative CT and reflect this angle intraoperatively. However, there are two trans-epicondylar axis. The lateral reference is the same, the apex of lateral epicondyle. However, medial side is the two reference point. The first is apex of medial epicondyle. Another one is slightly posterior to the medial epicondyle. so-called sulcus. Clinically, you can feel the dip or defect just posterior to the apex of the medial epicondyle. We call it the sulcus. So critically, this dip or defect is the center of insertion of MCL. So, uh, so in most surgeons use Trans-Epicondylar Axis as the line between the lateral epicondyle and sulcus of the epicondyle. We call it surgical epicondylar axis. And on the other hand, the line between lateral epicondyle and apex of medial epicondyle, we named it surgical, clinical or anatomical epicondylar axis. Which is better, but most surgeons think this line.
Sulcus.
Surgical. Yes. But the problem is how to measure this twist angle or condylar angle. We need CT scan. But the problem of CT scan is a slice should include 4 reference points here, and this is the lowest point and lowest point. So it is virtually impossible to take the 4 reference point, perfect reference point in the same the same frame, or 3D. So we need 3D reconstructed view, or Kaneka's view.
Superimpose.
No, superimpose or 3D reconstruction. Now, so using the 3D templates or superimpose view, or Kaneka's view. No, this is the view. The patient sit on a little bit high chair and flex approximately 70 or 80 degrees, and X-ray beam is come from the front to So that is called as Kaneka's view, because Dr. Kaneka's reported this view, or condylar view. Or maybe tomorrow I will show you how to take it. Sorry, I don't have this slide just now. Only the Kaneka's view can detect precisely 4 points in the same plane. Anyway, the problem is the important thing is our reference axis is different in kinematic alignment and mechanical alignment. That is the problem. So this is the difference. Why such a difference is a rise? Because so concept of is flexion and extension is quite different. Because in the kinematic alignment, the knee moves around the femoral component. So in the field of kinematic alignment, so tibia move around the femoral condyle, like roller on the ground. On the other hand, mechanical alignment, the knee motion is regarded as swing. So this is the TA, and this insertion of two ropes insert to the medial epicondyle and lateral epicondyle. So this is based on the major resection, because femoral component anatomy is the base of knee flexion extension motion. On the other hand, ligament tension, ligament balance is the path most important thing in the mechanical alignment to make the balanced flexion and extension gap. So this is the difference of two philosophy. This is the two philosophies. Compared to the TE and CA, it's a slightly difference. In terms of the rotation, TEA rotates externally 2.3 degrees in one report, but it's quite variable among the reports among the patient. In terms of corona plane, it's approximately 2 degrees. It varies in TEA and locates slightly proximally and slightly anterior. So this is the angle, the rotation angle between SEA and TEA. It's quite variable. So roughly saying between 2 degrees and 3 degrees to 5 degrees. But one report showed that the male patient rotates more than the female patient, and quite a difference among the races, the populations. But nobody knows the truth. So even the gender difference is quite a difference among the report. So we should consider the individual if we accurately restore the patient native kinematics. But practically, if we cut the femoral in 3 degrees external rotation in all cases, because if we in pre-operative X-ray show that this twist angle is 7 degrees, sometimes it's possible 7 degrees. We cannot follow 7 degrees because of the posterior cutting thickness is quite different from the component thickness. So it is quite safe to cut in 3 degrees in external rotation in all cases. But basically, the mechanical alignment is a non-anatomical operation. So this difference doesn't matter. In terms of coronal plane, if the patient have the 3 degrees of medial slope of joint line, we always cut the perpendicular to the mechanical axis. That makes the difference of the ball cut thickness. Then this imbalance of gap can be adjusted by soft tissue release. So that's why the mechanical alignment is reconstructive operation. But kinematic alignment is the resurfacing operation, repairing operation. Well, that is the philosophy is completely different. So, one evidence is the quite variable, quite a wide variety of the rotation twist angle among the patient. Okay. So, but in fact, in the 3D analysis, actual reflection the extension axis movement is comes around the contralateral cylindrical axis or contralateral axis. It's very closer to actual flexion extension axis. So than Trans-Epicondylar axis. So in terms of the kinematics or morphology, cylindrical axis follow the native one. But in the other hand, if we follow this cylindrical axis, gap can be imbalanced. Okay, the following will be taught tomorrow. Okay? Okay. ということで、2つの軸があって、それぞれの、あの、切り方で違いますよということですね。で、なんで違うかというと、そういうふうな感じ。要するに、メカニカルは